My name is Ami Patrawala, and welcome to our webinar today, Use of EMRs for TB Programs, the Benefits and Challenges. We will have two case presentations and then some time for discussion and questions. So let me go ahead and introduce both of our speakers today. Dr. Michelle Haas is the Associate Director of the Denver Metro TB Program at Denver Public Health and is an Assistant Professor of Medicine in the Division of Infectious Diseases at the University of Colorado. In her current role with the Denver Metro TB Program, she supervises outreach services within the TB program, provides oversight to the management of active and latent TB, and provides consultative support for the Colorado TB Control Program. Michelle, thank you for being with us today. Our second speaker is Andrew Tibbs. Andy is the State Epidemiologist at Massachusetts Department of Public Health, Division of TB Prevention and Control. He maintains surveillance data for the TB division and the refugee immigrant health programs as well. And Andy, thanks so much for being with us today. Our first presenter will be Dr. Haas, so I'll turn it over to you.
Great. Thanks so much. And thanks for the invitation allowing me to present our experience. So what I'll be talking about is EMR-based tools to enhance TB preventions and some of the lessons that we've learned in trying to change our electronic medical record. So I thought I'd start by just describing our context a little bit more to give the audience sort of the landscape that and then our context that we're dealing with. So the Denver Metro TB program is within Denver Public Health, and Denver Public Health is linked in a way to Denver Health Medical Center. So Denver Health Medical Center is the care center that is a public safety net hospital, and we are all under the umbrella of the Denver Health Hospital Authority. However, we are separate entities, so we are our own sort of separate public health program, and our funding streams are slightly different. Where we sort of overlap is, so we overlap geographically, so we're on the same campus as Denver Health Medical Center. And we have, in the past, prior to this new EMR, shared some limited resources in the sense that we share the laboratory that's at Denver Health Medical Center and the pharmacy, and then also radiology services. And so, in some ways, that's actually been quite nice because we can, if I have a patient that's ill in TB clinic, I can send them right over just, down the street, if you will, to Denver Health Medical Center. And then in some ways, we've also served as a referral center for primary care providers because we are on the same campus and have shared these resources together. Because of that sort of shared relationship, and how we've been linked in the past, when Denver Health Hospital Authority decided to upgrade the electronic medical record, we were part of that upgrade. We weren't necessarily part of the decision to move to Epic, which is our new EMR, but we're basically told we were upgrading and that we were going to have to use Epic, and so we were in this very unique position of trying to use what's largely a sort of a medical EMR, not really an epi surveillance EMR, for the things that we needed for our TB program. And so obviously that presents some challenges, which I'll talk about. There's also some opportunities for us to become better connected with Denver Health Medical Center, which I'll also talk about in future slides. So as I mentioned, so Denver Health Medical Center, which we have some shared patients with and share geographic space with, is a vertically integrated healthcare system. And so there's a network of primary care clinics, including some primary care clinics that are based in our Denver public schools. And we are a public, Denver Health Medical Center is a public health safety net hospital. And so we can see individuals who live in Denver County, irrespective of payer source. And Denver Health serves approximately 150,000 individuals. Denver Health has been collecting country of birth at registration since 2003. And so that was actually one of the first things that we wanted to try to preserve going forward, because we had already seen some early opportunities to utilize that information for prevention, particularly for programs for TB prevention. And so one of the early pilot programs that have been developed prior to our new EMR was what you see here, this pilot intervention to improve TB infection screening at Denver Health Medical Center. And so this was not through Denver Public Health, not through the TB program, but actually in primary care clinics, where they developed an electronic medical record tool that utilized birth country in its algorithm to identify patients who might be at risk for TB, and then alerted the provider to offer screening. And at that time, it was tuberculin and skin testing. And so it was a pilot program, but what we found, or at least what my colleagues found, was that using those tools in the electronic medical record resulted in a 183% increase in adhering to screening recommendations. Now, while that might sound really impressive, it's, we went from 8.9% people at risk being screened to 25.2% of patients who are at risk being screened. So clearly there are some more opportunities for improvement. But, again, that sort of, we wanted to make sure, because we'd had some limited success in the past in using tools and an electronic medical record, we wanted to try to preserve that as we move to this new EMR. And so prior to our new EMR, which is Epic, we had really 4 different systems that were utilized for patient care. So there was this state surveillance database that you can see pictured here. And that's where most of the work for our TB program was situated in terms of documenting patient follow-up, documenting latent and active treatment, documenting contact investigations. Most of that was in this state surveillance database. And that database actually didn't really talk to the other electronic medical record tools that were part of Denver Health Medical Center. And so that was a big challenge for providers who could sort of tell that patients were being seen in TB clinic, but they didn't really have any more information because they couldn't see our notes because that was separate. And then at that time, Denver Health Medical Center was actually still capturing, documenting patient care on paper. And so, again, moving to an EMR that we shared also presented some other opportunities. So, basic communication could improve, and then potentially some other interventions for TB screening in primary care. And so, in our prior EMR, we were able to do some surveillance work or try to really survey the landscape to see how much TB testing was happening even after that original pilot program that I described earlier. And so what we were able to do even prior to implementing our new EMR was look at how much TB screening was happening in primary care clinics through a data warehouse that captured labs and visits and ICD-9 codes. And so you can see what we had been able to do prior to Epic here, which again is something we wanted to preserve going forward. And so very briefly, you can see that from 2012 to 2014, just about 160,000 patients were seen in our primary care clinic. So these are all patients that were not seen in TB clinic. And then we identified that 35,000 individuals were born in a TB endemic area. And of those, only 8% of those individuals had had an IGRA test done during that time period. And so then we were also able to define how many of those individuals had had a chest radiograph. So you can see that here in this graph captured here, and then how many had started latent TB treatment and then completed therapy in the primary care setting. And so, knowing that we wanted to be able to survey this going forward, we wanted to make sure we built those tools into Epic as well. And so, as I mentioned, we needed to continue to capture birth country. We needed to capture information on individuals with suspected or confirmed active tuberculosis for our own programmatic needs. And then we also needed to be able to monitor DOT doses for active patients and, hopefully partially replacing the state surveillance database that we had been using for that. We also needed to monitor treatment completion for latent TB, and then tracking contacts, which was particularly challenging when we went to our Epic analysts to ask them if we could do that. It sort of blew their minds a little bit to say, well, yeah, we do want to link patients to one particular individual. And, very quickly they said there's no way that we can do that because of a feature called MyChart where patients can log in and see a lot of their health information. As I'll talk about later, we were able to create a workaround so that we can, in a somewhat limited way, track contacts in Epic. But that was one of the first big challenges, and that was an ask that we couldn't get done in Epic, at least initially. And then we also wanted to, as I mentioned, define the latent TB care continuum, and then also provide more support for primary care providers in providing a quick and easy TB risk assessment that providers could use if they were going to try to identify patients at risk for TB. And so when we were describing all of our needs to our analysts and trying to figure out how we could move forward, because really nothing at least that we could tell had been built specifically for public health tools in Epic, at least some of the tools that would fit our needs. And so our Epic analyst said, well, what about an episode of care? And we said, well, what is that? Like, nobody really knew what that was. And what this is it's a specific tool in this EMR that allows you to not only capture discrete data elements in almost in a form that can be attached to this episode, but it also links visits under one particular problem or issue. And so this tool was originally developed to track visits related to, say, pregnancy. So if you click on this tool in this EMR, then you can pull up all the visits and all of the treatment related to that particular problem. And so, as I mentioned, it was developed for pregnancy, cancer treatment, but we, once it was described to us, we thought, oh yeah, this might be a very reasonable thing that we could use to collect the data that we need for both latent and active TB in terms of specific details about treatment, and then it allows you to link all of those visits together. And so what you can see here on this slide, just over here to the right, is just a list here of all of the different episodes that are currently, at least a snapshot of the ones that are currently available in this EMR. And so this actually here is an example of an episode and what kinds of data can be captured. And so this is a patient with suspected or active TB, and this would be their episode. And so we can capture information based on class, which is important for us, not obviously for not for primary care, but more for our tools. And then, if there's a situation where we empirically start TB treatment, and then in the end we find out that that patient doesn't have TB infection or disease, then there's some additional information that we can collect down at the bottom of the form that you can see sort of through here that would allow us to sort of track their ultimate outcome that you can see here. So, in summary, the episode, first we were quite skeptical, but it has allowed for us to collect data in a way that I don't know that we could have otherwise through notes and other tools. And so then documenting directly observed therapy was also a big challenge. And so the way that we eventually decided to do this was to capture medication in a flow sheet. And you can see an example of a flow sheet here where you can see the different details that we collect, so in the different doses, and then also whether or not side effects had happened and if it was directly observed therapy or not. As it turns out, trying to sort of summarize treatment weeks with this tool is also pretty challenging because you're scrolling through individual days. And so we ended up having to create a workaround report that summarizes the treatment weeks and then moves them or dumps them into a different report that we can access that's actually outside of Epic. And so this is an example here of that particular report that pulls data from Epic and then summarizes that in treatment weeks, which is visually much easier to count treatment weeks and try to see where patients are at. And then, as I mentioned, so we weren't able to link contacts to a specific patient in Epic, but we were, as I mentioned, able to create a workaround where we created a unique identifier for the index case and used that unique identifier in the contact episode. And then our epidemiologist was able to pull that together into a report, and you can see an example of that here in this slide, where there's the different unique identifiers and then different which class the patient's at, what their last quantiferon was. And then down here at the bottom, you can see an example of the contact episode in terms of the information that we collect on contacts in EPIC. And then, as I mentioned, we wanted to also be able to track and define the latent TB care continuum for patients with latent TB, not only for the TB program, but also try to create a tool that could easily be used in the primary care setting. And so that's what you see here, and you'll see a list of the different clinics that we have, sort of their names here, and then different additional details about whether or not latent TB treatment was offered or not, and if the patient accepted, and then if they didn't accept, what are the sort of reasons why they didn't accept treatment. And so this will hopefully allow us to collect, data in more granular, detailed way on the latent TB care continuum, not only for our purposes, but again for primary care clinics. And right now, we have at least one primary care clinic who is open to the episodes, has actually created some workflow to use these tools in EPIC to start collecting data on their latent TB patients that they identify and start treatment on for latent TB. And then more recently, our TB epidemiologist, who's Kaylin Aona, I have to call her out by name because she's absolutely outstanding, identified this business intelligence tool called Tableau that can actually pull information from EPIC and summarize that. And that you can see an example of here. She actually taught herself how to use Tableau through YouTube videos. Hopefully she's okay with me sharing that, but she's really outstanding. And so what she was able to do was use this program to pull data from the episodes that I just showed you. And so what you can see here is just a couple of examples. So these are data here, latent treatment initiation, the data that we have so far on our new episodes in terms of the offer status, offer treatment, and accepted, and then some of the reasons that we have so far on latent treatment not offered. Now, these data right now are just from our TB clinic in terms of patients that we've seen for latent TB, but hopefully this is something that we could potentially offer to primary care clinics who use those tools as well and use those episodes. So there have been a number of challenges. One of the biggest disappointments, I think, was that Birth Country, despite advocating, pretty loudly to have Birth Country as a hard stop, which is, what it was in our prior EMR. It's not a hard stop in EPIC, and it's very hard to find. So as a provider, if I'm in a primary care clinic, I can't find Birth Country in the usual demographics. It's buried in there, and it's really something that you can only see in specific fields in registration. Our EPIC analyst was able to create a different view so it can pull it in for TB clinic, and then also created something similar under what's called additional demographics, but that had to be built, and not all primary care providers know about that, and so that's created some additional challenges. Also, we're not sure about the accuracy of Birth Country being collected and whether or not it's being collected. We have some data on that, so I think some primary care clinics are better than others. And so that's another thing that I think going forward, we'll need to think about a project to validate that and make sure that Birth Country is being captured in an accurate way, because currently you can get through registering a patient without capturing that. We've gone through, I've shown you sort of the sort of final and most recent product for the episodes. We have gone through multiple iterations, I guess 2 iterations for the episodes. This is the second one, and then a second iteration for our TB risk assessment, and then also a second version for our notes. And so in terms of how we want to document other things that we don't need to capture discrete data elements on. So there have been some, had to go back and forth with our EPIC analysts to get things built. But on the other hand, we feel very fortunate that we've had one analyst that was able to just work with us and get some of these things done for our program within the past year. We've also wanted to be mindful of whatever it is that we build for TB clinic, that they're feasible if primary care clinics also want to use these tools to start increasing TB screening and latent TB testing in their settings. We've had to have a separate report for linking Epic to DOT, and probably the biggest thing is that change is difficult. I think some of the successes that we've experienced is that now we're well integrated into Denver Health Medical Center, and so there's greater transparency for what's happening in TB clinic, and that can also be a learning opportunity for primary care providers, who occasionally have patients that come to our clinic, and seeing how we approach TB care. It's also, I think, good that that providers can use our tools, and then they can refer patients to us with an electronic referral system, so that's helpful. And there's also the potential, although there's still significant barriers, but I think there's still some potential for us to share our tools with other Epic users, given the large number of people that or systems that are using this EMR. So with that, I'll stop and turn it over to Andy, and I know we're going to save some questions to the end. So thanks very much for your time.
While Andy's slides are being pulled up, I'll just remind the audience that if you have a question, please type it into the box, and we'll have time for discussion after Andy's presentation. Thanks.
A quick way to skip back to the beginning. Hey, everybody. My name is Andrew Tibbs. I lead the surveillance and epidemiology team here in Massachusetts for the TB program, among other things. So, our experience is a little bit different than Michelle's experience, Dr. Haas, in that, they, had the opportunity, albeit forced upon them, to create something from scratch, work directly with an Epic analyst to craft a custom solution to needs in their EMR for, TB program requirements. And, this isn't necessarily a feasible solution for everyone. So, I wanted to talk about trying to work more with existing EMRs and in places where infrastructure already exists to make changes, or perhaps if you're trying to build an EMR from scratch, what are some of the questions that you'll need to come up with? And so to understand a lot of this information, you'll need to know some relevant things about Massachusetts. First of all, in Massachusetts, what's a county? We have 351 local town or city level public health jurisdictions, and all of our public health TB services are contracted out, usually to hospitals, sometimes to health centers. So people who need TB services go to state-sponsored or state-supported TB clinics within those health centers or hospital locations. We use the Maven surveillance system. So, where Dr. Haas was talking about, building capacity to monitor DOT and to track contacts within the EMR system that they're using at their TB clinic. In Massachusetts, we're using a state surveillance system which already has a lot of those capacities built in. It, integrates well with other infectious disease conditions. And, we're not super interested in starting from scratch on creating an EMR, electronic medical record system, when we provide no direct medical services to our patients. So we're more interested in finding a way to link that medical information, when relevant, to our already existing surveillance system. We have a medium incidence for TB disease, so while it's on people's minds, it's not necessarily at the forefront of people's minds. And then, kind of unique to Massachusetts, is a TB infection here, whatever that means, has been reportable since the early 2000s. So we have considerable amount of experience, if not necessarily utilization of that information. So how did we kind of generally get into the EMR business? And, this is kind of getting at that question of, we all know specifically why we need to get into this business, but why? What are the greater questions? So, one is that TB incidence is declining in Massachusetts as it is across the country, TB disease incidence, and so we're interested, if we're trying to get to elimination, in using more prevention, more tracking and completion of therapy for patients who are infected with TB rather than who are sick with TB, and that increases the volume of patients by an order of magnitude. So we need a more efficient way to track this information than via the paper systems that we have relied on to date. Massachusetts has a long history of public health responsibility. The first health centers were here. It's just something that the environment in Massachusetts is inclined towards public health innovation, and we're proud of it. In Massachusetts and I think elsewhere, we're also moving to shift the diagnosis and treatment of TB infection to community providers and out of TB specialty clinics, save those resources that we have for truly complex TB disease cases, medical consultation, and get, the relatively straightforward testing and treatment for TB infection out into the primary care clinics. And, they're not going to buy into our TB surveillance system to do paper-based reporting, et cetera. So if we can't talk to the EMRs there, then how are we going to get information from them? And then lastly, I have an unhealthy attraction to impossible tasks. So this is just one more of those. So the case, we build this presentation as a case presentation. So the case we're going to talk about here is related to the project. And so Massachusetts received a grant from the CDC funding a demonstration project for TB testing and treatment, scale up of TB and testing and treatment in one community health center. And so, I was talking about moving the diagnosis out to community providers from specialty clinics. And the one specific example I'll talk about today is that the Lynn Community Health Center is doing our Test to Treat demonstration project. So they use Epic systems, so this is going to be an Epic process. But again, I want to emphasize that the questions and barriers and things that come up related to this are applicable across the board, not necessarily specifically to any one state, one TB program, or one EMR system. So currently, TB infection is reportable in Massachusetts. We get them via paper-based forms. They're read into a computer more or less automatically. We get basic demographics, test results, risk factors, and reporting facility providers. And then we get follow-up information. But the problems with this system are that clinicians are pretty much universally terrible reporters. There's a few exceptions, obviously. And then, like I mentioned, the follow-up information is limited only to state sponsored or supported TB clinics. For the most part, we have some independent agreements with various community health centers, kind of as a voluntary participation so that they can, provide more services to their patients with TB infection. They provide data to the state so we can provide those services more effectively. And then, this is my own personal pet peeve. It's 2017. Why are we still using fax machines to send this data back and forth? We should have a better way of doing it. And so in 2010, we began kind of generally experimenting with the idea of electronic data transfer. We approached our TB clinics to open conversations about electronic data transmissions from medical records. And, we went in thinking that the incentives, with no money, of course, but with the incentives of thinking that you wouldn't have to do these paper forms anymore and there would be no more double data entry would be sufficient. And then still in 2010, we ended the experiment because we quickly realized that the EMR records that existed in many of our TB clinics didn't have the appropriate data. They didn't collect TB risk data. They didn't have, information on treatment completion or full information on chest x-rays. A lot of it's captured in narrative notes. So, they just didn't have what we needed. And the technical expertise to extract existing data was limited. These are small clinics within large hospitals. They aren't very priority. Wasn't a priority for them to go do TB. And then every clinic we have, all 22 of them here in Massachusetts, use some kind of different version of the system. Like really, all 22 of them use a different system. No two are the same. Also, we realized that, our incentives of no more double data entry was definitely not enough. So they needed some money. So we fast forwarded to 2016 with a break here for a few important intermediary steps. First is, we realized pretty quickly that we really had to simplify the information we were requesting to the basic information needed to track patients through the care cascade, the LTBI continuum of care. We made improvements to our surveillance system to better receive that information and to provide better feedback to participants so that there would be something in it for them. We maximized the availability of electronic lab reporting via IGRA, so we knew who we should go ask for information for. We tried to leverage, this kind of, national target to have everyone up and running on an EMR system, so we knew that people would have these systems and want to participate. The easy part was getting a demonstration project grant. But why the grant matters. So it's a demonstration project, and in order to demonstrate, you have to have something to show. The volume of testing and treatment expected at this one site would have overwhelmed the current paper-based system. We're not upping a lot of staff time. We're not putting a lot of additional resources into the system. So or rather what resources we want to put into the system, we don't want to spend on filling out paper forms and faxing them to us. So we needed to move towards EMR-based stuff anyway. And then we had a previous history with the health center, which guaranteed that there was kind of going to be a core interest in helping us work through the problems related to this. And so we went back, and so we tried this same approach again, but this time in a health center, not in a TB clinic. We're giving them some money now, so that helps. But there were still complications. The health center already used the EPIC system, which is not the most modifiable system post-implementation. So, it's good that you can get in on the implementation floor, but a lot of places these things are already up and running. And then this version of EPIC was an instance managed by OCHIN, which is a collaborative of health centers, which started in Oregon and now is basically nationwide, who banded together for many reasons, but one of them was to gain bargaining power with EPIC to get changes made to the system quicker. But that meant for us, trying to do this project, depending on what type of change we needed, the Massachusetts Department of Public Health said, hey, we need this change to make this project work. Lynn Community Health Center then had to ask OCHIN then had to ask EPIC, and then EPIC would make some change, and it would come all the way back down the chain to the public health department and say, hey, is this what you actually needed? And we would have to say yes or no, et cetera. So that process began with creating a scope of work, which started with a data dictionary. I can't emphasize enough how important this was. Just starting from like the bare bones level of saying, hey, these are the elements that we're interested in. And this is the priority order in which we need them. So for the project to succeed, these elements are required, these elements are high priority, these elements are low priority, and then et cetera throughout. So that's priorities. And then turning it over to their internal IT teams to go through and review existing data fields, find out whether or not they even exist, how complete those fields are in the current structure, what the quality of the data is in them, and then where in the user interface they appear and who can enter data into those fields. And so that last piece is much more important than you would think, because not everyone has equal access. So then we identified, based on that assessment, any change requests that were needed, new variables, new hard stops, new moving variables to new locations, etc. We identified any reporting that was needed, whether it was a front-end dashboard for clinicians to use versus line-level extracts on the back end that would be importable into our surveillance system. And then we submitted any change requests to the EPIC team through OCHIN. And then we waited a really, really long time. And then once they come back with new reports and changes, we'll test them and determine any problems or bugs or successes or unexpected bits. So some examples are we added the country of birth variable. We wanted to add the country of birth variable and make it a hard stop, just like Michelle was saying. This is one of the key risk variables for TB. We didn't actually think it existed in the system because we couldn't find it. And we wanted to make it so that when people came through registration, they would, have to fill it out before they moved on. We wanted to collect all of the information that we needed into a single extractable report, which didn't exist. We could get a lot of the information already, but we couldn't get it in one place. We wanted to update their risk assessment. They had an old risk assessment that happened to have been built into the system sometime prior, but which was out of date. We needed to create a flow sheet. Michelle showed you an example of something that used a flow sheet in Denver, but I'll talk a little bit more about that in a minute. And then we didn't know whether or not we needed a dashboard for the clinicians to use, et cetera. We did have to create a couple of workarounds because this is not news, but EMRs are not designed with public health surveillance in mind. The country of birth stop had to become a yield, and the reason for this is that it turns out country of birth actually exists in the EMR already. In our case, I don't know where it was in Michelle's case, but in our case, it turned out to be in the death certificate section of the EMR. So you didn't have to fill out the country of birth unless you were filling out a death certificate. We moved it to some place where they could do it in registration, but then, kind of happenstance, all the changes we made were made throughout the entire OCHIN network. So 84 health centers suddenly had this feature they didn't ask for, and we had to backtrack. Chest x-rays are not captured in structured fields. So, they get chest x-rays from an outside provider at this health center, and they come through the system as like the PDF x-ray report, and they're not transcribed into the Epic system. You can just click a link and go look at it, but that's not really useful if you're trying to extract the results for the x-ray directly, into a report. So the treatment regimen and completion data was not very complete or accurate. So, we are working around this at the moment by taking the date the completion letter was printed. So Epic, tracks system changes like printing of a letter. And so we can say, okay, this TB treatment completion letter was printed on X date. We're going to use that as a proxy. Obviously, that's not ideal. Especially considering the letter can technically be printed at any time. And then, we're working to use encounter data to track treatment progress, just like Michelle is, but, we haven't, since we're working not from scratch, but from trying to implement this into an already existing system, our progress has been a little bit slower. So the bottom line is we really had to reduce, and these are where it really gets applicable to all EMR systems in all health departments. We really had to really think very firmly about what we were asking about and reduce it, and compromise on some formally required elements. We had to accept that, getting garbage in meant that we would get garbage out. Just because the EMR collects this information does not solve the problem that clinicians or clinics or anyone else really are not always data people, and they're not always thinking about those things. The project still couldn't be done without workarounds and project-specific fixes. So, the good news is it can be done. Here's a list of specific problems. So there's a lot of data not captured in structured fields or more than one place to put it exists. And so depending on who's putting it in and what time in the process they're doing it, it might be in different places. So data from sources outside the health center that come into the health center to aid in the evaluation of a patient might not go to the right place, or might not even get put in. They might just be attached. And then, clinicians have a lot of leeway in how they enter that information into the system. So, being successful in getting data out of an EMR requires being successful in getting data into the EMR, and that success requires systemic change. And TB is not a priority for systemic change, either culturally or mechanically. So it's hard to change the mechanics of the system that exists already if TB is not a priority, and it's hard to change people's minds about how they enter data if they're used to doing it a different way. It takes forever, like a really long time. So we're getting pretty successful with this project, but it's been more than a year that we've been working on it. And then this is the really kind of saddest piece in my own personal take on this, is that all the work that we're doing for this health center is not really generalizable to other locations. You know, other Ocean Epic users will be able to take advantage of these features. Other Epic users, to some moderate degree, will be able to take advantage of these features. But, you know, in reality, what works in Massachusetts doesn't work everywhere. And so to really make a difference, we need to step back and look at things kind of on a national level, get as much buy-in as possible from the EMR manufacturers as we can to build in public health requirements, either out of good faith or to, you know, out of grant funding or something, some reason that they can get in there so that we can get public health information out in kind of a universal language of some kind. That being said, we are successful. We identified 55 fields and prioritized them that were important to tracking TB infection data in a public health way from a private health clinic, and all 55 that we prioritized are now extracted and transmitted electronically. We can link health center billing information and pharmacy data to line-level patient information, so we're doing good there. And so this proof of concept, is a proof of concept. It's working out. And so that's where I'll end for now, but I'm happy to answer questions along with Michelle in this discussion.
This is Ami Patrawala again. Thank you so much for that presentation. I think we do have some questions for both you and for Michelle. If the audience can feel free to type in more questions, we can see them, and we will read them out and have some discussion. Andy, one question I had was sort of, what are your next steps now that you've done this with one health center? Is your plan to go ahead and do this with multiple other health centers? And do you think that it will become easier, or do you think you're going to continue to have issues because each health center is a little bit different?
Yeah, so I think that, obviously we would love to get more and more health centers online. I think that, getting them online will kind of be directly correlated with how easy it is and what we can offer them in terms of incentives to get them on board. I think the easier it is, the fewer incentives are needed, and so I think we may start, there are other Ocean Epic health centers in Massachusetts, we might start there. We'll probably start with the TB clinics. Again, now that we have a little bit more experience with the process, we know exactly what we need and what we can ask for, and they already, receive some state support. So yeah, I think that the next steps are kind of pushing outwards. That being said, I think it's going to take a long time, and it's going to be pretty difficult. I think even within the system where we're working now, improvements can be made. We can make further use of the episodes of care, like in Denver.
Right. I think along those lines, there was a question also related specifically to Massachusetts in the public health clinics. So this is outside the health centers. Are they also using Epic? And if not, I'll ask, how would you have to create something brand new for them?
Yeah, so some are using Epic. They're not all using the same version of Epic, which can make a difference. And some are not. So there are 22, give or take, TB clinics in Massachusetts, and, they're all, no two of them are using the same EMR exactly. And so we would have to make customizations. I think that if you used the knowledge that we put together in working with this one health center, the benefits for kind of the general questions, knowing where the stumbles were, what variables need to be extracted, what we need to prioritize, I think it would go faster even in systems where they weren't using Epic.
Right. Well, let's move to some of the questions that are being entered here. Dr. Haas, I think there's been quite a number of questions asking about the field workers and directly observed therapy and how that's being documented, and also if the field workers are inputting data directly into Epic.
So in terms of how our DOT staff or how our outreach staff enter information into Epic, so I think there was one question about do they have laptops? So they do have laptops, but they haven't. It hasn't really made sense for their workflow to open up the laptop and chart after seeing each patient. Some of it just has to do with not having good internet access. We've created some workarounds for that. But also, sometimes, some of them have candidly expressed that they're concerned about opening the laptop just because of where they are in the city in terms of the risk for the laptop being stolen. And so that hasn't been part of their workflow. So typically what's done is they'll see patients and then come back to the clinic and document DOT doses. And they'll document the doses in the flow sheet example that I gave in the talk.
And I think somewhat along the same lines, I don't know if you can see the question from San Francisco. If you could say a couple more words about the system that the DOT log data is exported to. I think that is Epic that they're entering into directly, but then a little bit more about the surveillance system. So the flow sheet's entered into, I'm just looking at the question now. So the flow sheet's entered into Epic, and then Kaylan created a report that pulls that data and then actually puts it onto our secure server. And so it's actually an HTML file that we click on, and then it shows us the patient's name, medical record number, their case manager, and then it summarizes their treatment weeks. And so that's been the workaround that we've had to create so that we can quickly say, okay, this person's had 11 out of 26 weeks of treatment, and they're in their continuation phase. And then what surveillance? I'm just looking at. And so that's what it's exported to, and then the surveillance system that's used. So there isn't really. I don't know if that's a question about contacts. So we still utilize the state surveillance database for contacts that we don't ever see. So we have a process. We haven't fully implemented it, but eventually we'll have a process where we will upload contacts from Epic and then put them into the state surveillance database. And so the way Kaylin could probably speak to this better than I can, but I think the way the data will have to be transferred is it'll go to an Excel spreadsheet from Epic, and then that will upload to the state surveillance database. We're looking into being able to enter patients into Epic that we actually haven't seen that are still in Colorado. Legally, that's been an issue for us because Epic has said that we can't enter in patients that don't physically come to clinic. And so that's a big challenge for contacts that they see patients, that are seen elsewhere. We're actually, my boss has talked to the director of public health, who's talking to legal to see if we can start entering people that we haven't actually physically seen, because we're ultimately responsible for contacts that we may not necessarily see. So I'll have to give you guys an update about where that goes. Yeah, I think that may be an issue that a lot of sites will be dealing with, not only for contacts, but also for things like consultation that we might do remotely within the state and that kind of thing.
That's the other thing we've talked about. Just like if we do an e-consult, if you will, or sort of a warm line type consult, can we start entering? For patients with active TB. We'll do consultations on patients with suspected or active TB across the state. Can we start capturing what we say? I mean, there's a strong argument to be made to capture that data in an EMR because we're giving recommendations. And right now there's not a great workflow for that. So that's part of the conversation as well with legal.
I think there was a related question, Michelle, about whether lay health workers can enter DOT side effect information. Is there an area where they can free text if they have side effects and things like that?
Yeah, so our workflow is that, we want our staff to document not only, they can document in the flow sheet, but there's not that much, it's just a little clunky. And so really our workflow has been to document that in the patient's, in the notes. So if they see someone and they're vomiting, and they call the nurse and, call me and they get recommendations, then that note has to, and what was done and the symptoms have to be documented in the chart and within just a follow-up note.
Okay, thank you. I think there are some general questions about privacy and protecting patient information and things like that. Did either one of you go through any specific training or hold any trainings or take any additional measures when you were implementing these things?
In terms of the, other than being a provider, and having to, as a clinical provider, we have to, there actually isn't really a course. There's an annual course that we take about privacy as part of Denver Health Medical Center. And so everybody who works in the Denver Metro TB program has to take that course just to remind about privacy. And it covers everything from how you document to how you hold a conversation in an elevator. So there is that piece of it. With contacts, again, it was, right now they're not linked in any way to a patient's chart. And so that respects their privacy from that perspective.
Right. I think.
I don't know if that answers the question, though.
At our institution, we also have EPIC, and we go through similar trainings. Andy, did you find anything differently with a health center site?
Yeah, so they go through their trainings and we go through our trainings. The biggest area where we had to really work things out carefully was in the transmission of data between their system and our system. So they were rightly cautious to let data leave their system in such detail, and we were cautious in how we kept it and stored it here. But that was all worked out in advance, the mechanisms by which that would happen, and approved by both institutions. So the trainings happen, and you're as careful as you can be. The systems are as secure as they can be.
Couple of other questions are coming through. So along the lines of trying to reduce paperwork, one of the questions here is, are your teams no longer using statewide TB forms? Have EPIC and Ocean been tailored to capture that same information? I think those are two separate entities, but.
Yeah, so, we don't use our state TB data collection forms with this one site where we have this data exchange functioning. Mm-hmm. And the hope would be that we would, at each site where we get this data exchange functioning, we would drop the state TB forms. That's the hope. So I think in terms of are we getting everything that we would have gotten, I think that to answer the question about customization and tailoring, the answer is no, we don't get everything that we got on the paper forms via this exchange, but we get everything we need to track patients through the care cascade for TB infection.
Right. Maybe over the last few minutes, we can take one or two more questions. And some of the questions that have come up are sort of about funding and whether implementing these systems, which we all have thought should make our lives easier and sort of more accurate, but does it really in the end require dedication of funding and more staff, especially in the implementation period?
I think, there's definitely some resources needed to make it work, is the short answer to that question.
Mm-hmm. From our perspective, I know there's a question about how much does Epic cost. I've actually tried to ask our, public health associate director about how much like our build costs, and we've not been able to parse that out in terms of how much money was spent for the TB program. I think it's a lot. I'm not sure how much that costs. In terms of has it improved our lives, I think there's some things that have been good about Epic, just in terms of ordering medications and ordering tests. I'm a little old school. I still miss paper, but I'm working through that. And then I keep trying to remind myself that hopefully by being connected to primary care clinics, that's going to create some more opportunities.
Right. And Andy, do you see a difference in the data coming in on paper and coming in through this Epic connection that you have with the Lynn Health Center? Have you been able to look at that at all?
Yeah, so we're just beginning to. So it took about a year to get the system up and running, and now we're getting some good data, and we are seeing improvements in data quality from the old system to the new system, and we are seeing, by simplifying the data we were asking for, and for really focusing on the care cascade, we're also seeing improvements in completeness. And so time will tell if that bears out, but we're hopeful that it will.
Yeah, well, I think that's really encouraging, and it's encouraging, hopefully, for everybody on the line who is, I'm sure, if not already engaging with EMRs, will be shortly in one form or another. I just want to take the last minute or two to thank our audience for being such great participants. The recording will be up in January on GTBI's website, and that will be the slides with the recording as well. And I want to give a special thanks to our speakers, both Michelle and Andy, for doing what looks like a lot of work over a long period of time and being able to give us some really great results here.
Well, thanks for the opportunity to present our experience. Appreciate it.
Thank you.